So, dear colleagues, I'm very pleased to introduce next speaker. This is Roberto Carassa, and I would like to give the floor to him to speak about the monitoring of primary open-angle glaucoma, whether the standards are justified. The floor is yours. You're welcome.
Well, thank you so much. I certainly would start thanking the organizing committee and Professor Carassa for the kind invitation to this outstanding meeting. And the topic of my presentation would be toward the way that we are now using for monitoring our open-angle glaucoma patient. And I will try to emphasize the advantages and the limits of the present technology. I will also try to focus on the major causes of artifacts that now we are having with our technology to help you in better understanding the results that you are getting from these techniques. Briefly, we all know that glaucoma diagnosis and follow-up is based on the analysis of morphology and of function. And we know that morphology is based mainly on, let's say, low techniques as ophthalmoscopy and photos, and on high technologies like imaging. It should be emphasized that at first, the first step of diagnosis nowadays is ophthalmology, which should not be considered a low-tech and not useful technique. On the other side, function is based on standard automatic perimetry, which is still the gold standard for function analysis, even if in specific cases some non-conventional techniques can be employed. So let's start talking about imaging. We know that imaging technology, even if can be questionable in diagnosis, it's certainly the major step that we can use for following up our patient on the structural basis. We have three main systems that are clinically used: the HRT, which is discontinued right now, GDX, which unfortunately, again, is not on the market anymore, and the OCT, which is the technology mostly used in our clinical practice. This is one of the most recent papers that appear on the Journal of Ophthalmology, which is showing us the performance of the three different systems. And these are data that are coming out from a huge clinical base on the big number of patients. As you can see, the performance of the three systems are quite interesting and very good, even if we have differences between the system. And I should emphasize that the GDX is probably the one with some worse performance, having quite low sensitivity compared to the other system. And the more balanced technology is definitely the OCT. What is this slide is showing that is that unfortunately specificity and sensitivity are far from being 100%. So what we are expecting is quite a significant numbers of false positive and false negative from the results of this technology. And in particular, as you can see, what we are expecting is quite a number of false negative, which means that, especially for GDX, we have a patient with severe glaucoma which are totally undetected by the imaging system. HRT is not detecting some up to 21% of severe glaucoma, while HRT and OCT can miss severe glaucoma in 5% of the eyes. And this is leading us to the major problem of false positive and false negative with related implication. In terms of the factors that affecting the ability of detecting correctly the presence or the absence of the disease in our patient, we can see that by OCT, up to 1 out of 4 normal patient can be detected as abnormal, which means we have a normal patient which is diagnosed as glaucoma. On the other side, especially for initial glaucoma, we can have initial glaucoma patients which are wrongly detected as normal in up to 15% of the cases. And this has obviously important clinical evidences. And this led recently to a major point that was raised by the Federal Drug Administration in the United States, which showed that there is an increased number of the so-called red diseases, which means patients that are totally normal, which are considered having glaucoma and are started on therapy. And this will obviously implicates costs in the health system together with ethical issues. So which are the causes of these wrong diagnoses that are made by imaging system? We have different sources which are related to normative databases, to limitations specific to each technologies, to artifacts, to diseases other than glaucoma that can mix up the results of our system. Let's talk briefly about normative databases. We know that each system has its own normative database, and being outside the normal limits does not mean that a patient has a disease. It just means that is outside the limits of the normative database that is within the system. So the first thing we have to think about is that a reference database can be non-representative for the specific patient we are testing. And if we look to the different databases in the different systems, we can see that we have huge variations in terms of number of patients included in the database and in terms of study sites that included the patient. We have systems where patients were coming from different countries, systems where the patient is coming just from one country with different ethnicity. And we know that different ethnicity can give us different results in terms of optic nerve and retinal nerve fiber layer thickness. Again, one other issue that can be considered is also the definition of normal, which, as you can see in the slide, is far different from one database to the other. If we look in details to some of these databases, we can see that in terms of ethnicity, we have very different percentage of population coming from, let's say, African descendant, Indian, Asian, or Hispanic. So in a database where no Hispanic, let's say, ethnicity is considered, the results can be totally misleading if we are testing a person from these countries. On the other hand, generally all the databases give the range of age included, but this can be misleading because if we look in details to the range of age, we can see that in some cases, let's say in the case represented here, patient older than 80 years of age included were just 3 subjects, and it's obvious that this cannot be considered a normal database or a reference database. So this is one of the major issues that we can have when we are testing a patient for, let's say, diagnosis. We can have wrong results based on a database which is not really representative. Then we have limitations specific to each technology. This is a very interesting paper by Makoto Araya, which is testing the test-retest variability of each system. It's quite obvious that if there is a huge variation between test and retest, this can affect the result of the system, especially during the follow-up. Here we have a slide coming from the study, the Imaging Glaucoma Study Group, that is clearly showing that a high percentage of cases that at the initial test were considered outside the normal limits, being retested were totally normal. And this, it's obvious as implication, especially in the follow-up of our patient. As you can see, this is a case where there is a local defect at inferior pole done by OCT. If you can see, the optic nerve is totally normal. The red-free nerve fiber layer image is totally normal, and the visual field is totally normal. This is a clear false positive, which is coming out from a OCT analysis. And again, we can expect 1 out of 4 patients, or 4 normal patients, having an abnormal result on OCT. And we have to be cautious when we are evaluating the result of our imaging technology. Definitely, inaccurate data acquisition can give us wrong results, and this is very important, especially during follow-up. This is an example. This is a case where you can see there is a lowering of the nerve fiber layer thickness at the superior and the superior nasal area. Let's say this was a patient. After 1 year, we retest the patient, and there is definitely a worsening because the patient from borderline become out of normal limits at the quadrant and the o'clock hours maps, and there is a clear thinning of the nerve fiber layer. Well, this is the same, actually, this is an artifact, it's the same patient tested and retested, and we have different signal strengths at the different moment of the examination. And what is coming out from this study is showing us that the lower the signal strength, the thinner is the retinal nerve fiber layer thickness. So if we are testing a patient and then when we are retesting the patient, the signal strength is lower, there is an artifact that is telling us that the patient is getting worse while is exactly stable and it doesn't need any additive treatment. And here, this slide is showing that at different signal strength, we can expect a different thinner of the retinal fiber layer thickness. Another sort of artifacts is related to difficulties in acquiring the images, and here you can see some misalignment, which are mostly related to blinking during the examination. Finally, there are, obviously, we always have to consider retinal optic nerve head diseases other than glaucoma. A test on a tilted optic disc would be abnormal because in the database, tilted discs are not considered. Or a huge peripapillary atrophy can give you a thinning of the retinal fiber layer, which is certainly not related to glaucoma. During follow-up, we have also to consider some sources of misinterpretation, like a cataract surgery, which are HRT, since this is changing the optical magnification of the fundus of the eye, can change the result of the HRT, and so we have, after cataract, to reassess the baseline of our system, refractive changes, axial length variation, glaucoma surgery. We know that after glaucoma surgery, there is a change in the shape of the cup, and this can mislead the results of HRT and so forth. On the other hand, we have to emphasize that in follow-up, OCT and generally imaging technology are absolutely useful to understand what's going on in our patient. This is a very recent study which is showing on a 5 years follow-up that the change in the thickness in the nerve fiber layer is predictive for the appearance of visual field defects. So if we are doing and following our patient, especially our initial glaucoma patient with imaging, we can intervene before the visual field gets damaged. Recently, Macular has been tested by OCT in order to increase the accuracy compared to the peripapillary retinal fiber layer thickness analysis, since 50% of the overall ganglion cell population is within the macular area, and the macular area defects seems to be more correlated to the functional defects. Unfortunately, as for false positive, Here again, the number of false positives still quite high, even if we are testing the macula, and this study was showing up to 40% of false positive, and here we have two examples of what we can expect as a false positive in a normal eye. But on the other hand, this very recent study is showing us that compared to a retinal nerve fiber thickness analysis, macular analysis is one of the variables which is most predictable for visual field defect, which means that if an eye has a macular, let's say, ganglion cell complex abnormal, it's far more predictable that it's gonna get a visual field defects when compared to patient with a ganglion cell compound totally normal. So this should be considered as one of the variables more sensitive to predict visual field changes. So how we can conclude? We show the limits of our technology, but also the advantages. I totally agree with this very recent editorial by Lee and Jampel, which is saying that imaging is necessary, but definitely is not sufficient in following our patient. Imaging technology is a powerful objective structural assessment tool that can greatly assist clinicians in diagnosis and managing glaucoma, especially in the early disease, and when it's used in conjunction with visual field test and clinical examination, which means that we always have to test our patient with visual field. We have to say that if by several problems we do not have imaging technology, it doesn't mean that we cannot follow our patient, because visual testing is still the gold standard for following up our patient. Definitely, imaging technology is very helpful to be used in conjunction with visual field to better understand what is happening to our patient. And clinicians need to understand the limitation of the imaging technology they use in order to better interpret the results that the system are giving us. But as compared to the current imaging technology, is there anything new that can have a better performance, capable of early diagnosis, or a better follow-up? Well, there's quite a bit of things going on. We have now then face images done by OCT, where together with the analysis of the thickness of the retinal nerve fiber layer, we are analyzing the change in reflectivity of the retinal fiber layers, and this would probably in the future help us to gain in terms of sensitivity and specificity. We have new parameters that are analyzed by OCT, like the lamina cribrosa in terms of changing shape or depth of the lamina cribrosa, and we will see in the future if this will help us in following our patient. And certainly the retinal blood flow imaging is becoming very important, since now we have been using the color Doppler imaging, which is good, but certainly can be considered questionable in terms of reproducibility. Now with the OCT angiography, we have far better results, and I think that we have to thank Dr. Kurisheva for his pioneering study with the OCT angiography, and she was clearly showing that that there is quite a difference. You can differentiate normal eyes from initial glaucoma and advanced glaucoma by analyzing the density of the vessel at the macular area, and this is not only useful for following and diagnosing our patient, but it's also very useful to better understand the pathophysiology of glaucoma. Finally, MRI, we heard before, can be used to understand, but obviously is not something that can be really used in the clinical practice. And finally, we heard by Francisca Cordero that we can detect in vivo apoptotic cell, and this I don't think is going to be very useful in the clinical practice, but mostly in the research. What about function? We have little to say about function. We know that standard automatic perimetry is still the gold standard to analyze function in our patient. And we know that there's not much in terms of new technology related to visual field testing, but there's quite a bit about new software that is helping us in better understand understand our visual fields and in better understand the change over time of the visual field. This is as an example for the Humphrey field analyzer, is the GPA2 follow-up analysis, and you know that we have two different kind of analysis. The event analysis, which is telling us if there is a change from baseline and is telling us where the change, there is a topographic analysis telling us where the change is happening, and then there is a trend analysis, which is very helpful because it's telling us how fast the patient is changing. It's going to give us the rate of progression. And this is a very good standard to follow our patient, but unfortunately we all know that the visual field in terms of reproducibility is far from being optimal. And this is where it comes that if we do imaging technology together with visual field, we are definitely gaining in better understanding what's happening to our patient. This is an example. This is a female patient of mine that was on therapy with a fixed combination of timolol bimatopros with a pressure ranging from 16 to 19, which means it's not a very low pressure, which had a change in visual field. In 1 year, she changed from the first to the second. We retested her after a couple of months, and the visual field was even far worse. So we retested her, and the change was clearly confirmed. And all these visual fields, in terms of reliability or fixation losses, were very good. What comes out from this is that by looking at the optic nerve, there was clearly something that was not going the correct way. We should always expect a pathologic visual field with a pathologic optic nerve. A normal optic nerve with a pathologic visual field, it's something not expected. It can be sometimes related to neuro-ophthalmological problems. The patient was tested by neuro-ophthalmology, there was nothing. And we decided just to keep the patient on the same therapy. And this is the follow-up of this patient up to 10 years. And the optic nerve never changed. And the reason was a total unreliable visual field testing, even if the reliability of each visual test was pretty much good. But as you can see here, this is a sort of false positive that we can expect from visual field. So thanks to the imaging technology, we can better understand if the visual test is reliable or not. Why visual test can be unreliable? It's a psychophysical test which has a learning effect, which has artifact, which can have a false positive and false negative. We know that over time the patient is getting better in his performance. We know that meiosis, lens opacities, refractive errors, or trial lenses can give us some sort of false positive results, but definitely the patient performance is critical to understand how reliable is a visual field. And finally, the test is obviously suboptimal in terms of sensitivity. We know that there is the need, let's say, of quite a huge number of ganglion cell loss before the visual field is capable to detect a defect. And here comes the fact that for very initial patients, in certain cases, in the use of non-conventional perimetry, FFDT or matrix can become useful in terms that they can detect earlier the disease than the white-on-white visual field. Is there anything new in the next future in terms of functional analysis? Actually, no. Visual field white on white is still the gold standard. There were different testing on other machines. This was one probably of the most interesting, what was the multifocal pupillographic perimetry, which was independent from the patient performance, but unfortunately there's not much to say about it because it was introduced in the past 10 years and never come really on the market. So what's become very interesting now, considering the limits of the functional techniques and of the imaging techniques, is that what we should do is to combine function and structure in order to get reliable results. And combining longitudinal data on function and structure will definitely increase our capability to evaluate glaucoma progression. This is a case of a patient. Again, I'm trying to show the relationship between function and structure, where over 10 years there is a very slight change in the visual field on the nasal quadrant. If we look at the imaging of the optic nerve, we can clearly see a huge change at the inferior pole. And this is the TCA analysis at the HRT, where it's clearly showing a change at the superior and inferior pole, and this is the trend of the change, which is clearly confirmed by OCT together with HRT. So this was a case where visual function was showing a slight change, but the structure analysis is showing a huge change. The patient was under therapy, combined therapy with 15 to 17 millimeter of mercury on diurnal curve. We decided to do at this point an SLT, which was not helping us much, so the patient underwent surgery. In this case, it was a deep sclerectomy with mitomycin C, which allowed to get very low pressure ranging from 10 to 12 and the complete stabilization of the functional and the structural situation. So here it's clearly showing how imaging can help the visual function analysis. Nowadays it's quite difficult. There is not a unified strategy to mix the data from function and structure. This was a way to use a specific statistical analysis, the Bayesian joint regression, which is using data coming from both structure and function together, but it's not so easy to use. This is another way, which is even worse, that was shown by the group of Bob Weinreb, trying to define an index coming from both structure and function and use that index to better qualifying our patient. But here again, it's quite difficult to use this. And we hope in the next future we're going to have something more clinical, useful to mix the structure and function results. So in conclusion, glaucoma is monitored with structure and functional tests. Standard automatic perimetry is still the gold standard for function analysis and should always be performed in our patient. Considering fluctuation and artifacts, a significant number of standard automatic perimetry tests are needed to correctly monitor the patient. We know that before having a significant data on follow-up, we need at least 5 to 6 tests, and nowadays what is suggested is to get these 5 to 6 tests in a couple of years to understand if our patient is a normal, slow changing patient, or if this is a patient with a very fast rate of progression. Optic disc and retinal nerve fiber layer imaging is a powerful objective structural assessment tool that can greatly assist clinicians in diagnosis and managing glaucoma, especially in the early disease. Limitation of each technology will be well known by the clinician in order to interpret the result correctly, and both functional and structural data should always be considered together in order to increase our diagnostics and follow-up capability. Thank you so much.
У меня есть два вопроса.
I have 2 questions to Professor Carassa, and running it in advance, I want to say that we will comment international survey today, but I think it's worth to ask this question. It is not.
I need my...
Сейчас я задам вопрос, потому что...
Can you read me? Sound check. Good.
Первый вопрос.
My first question is, based upon which ophthalmologists make this diagnosis, glaucoma? You remember these questions from the survey. How can we explain the fact that only 10% of ophthalmologists do trust modern visualization technique you just talked about in the diagnosis of glaucoma? But perimetry is even less trustful. There is data that less than 10% of doctors do trust. Only 1/5 based upon tonometry, but majority still look at ophthalmoscopy of optic nerve head, optic nerve discs. So how can you comment on that International Survey of Ophthalmologists in their position? Thank you.
Yes, thank you. Let's say that these results are not, we can expect this sort of result because still there is, I feel, a confusion about the fact that intraocular pressure is only a risk factor, as it is not glaucoma, while glaucoma is a sort of neurodegenerative disease which is affecting ganglion cells and the optic nerve. So when we are talking about diagnosis, I totally agree that the first step that we need to pass through is ophthalmoscopy. By ophthalmoscopy, we are easily detecting if the optic nerve is normal or abnormal. Unfortunately, the physician needs a good training in order to analyze by ophthalmoscopy the optic nerve. We have to say that imaging is not substituting a good ophthalmic analysis of the optic nerve. So we cannot say that if a doctor is not so good in understanding what's happening at the back of the eye, imaging is doing a better work. We have to increase the knowledge of ophthalmoscopy analysis of the optic nerve. Definitely, if we detect an abnormal disc, at this point, the patient needs to be checked by visual field and by imaging, and from then on, we start following up the patient. If the patient is normal, and we will consider the risk factors. If the risk factors give a higher risk of development of glaucoma, we will treat the patient. Otherwise, we will just follow the patient. If the patient has a definite glaucoma, he should always be treated, and from now on, we will follow him and treat him. So I think that if we feel that the measurement of IOP is critical in detecting and doing diagnosis of glaucoma, unfortunately, we are totally wrong. In the first presentation was clearly stated that we have a huge number of patients with glaucoma and with normal pressure. And if we feel that just the pressure is important for diagnosis of glaucoma, we are going to miss all these numbers. And this would be unethical from our doctor point of view. So whatever is a screening test for glaucoma, definitely pressure measurement is not the way to go. Ophthalmoscopy plus pressure will increase dramatically our capability to understand if the patient has glaucoma or not.
Большое спасибо. На самом
Thank you very much. In fact, Professor Carassa already answered my second question, because my second question was how to monitor. Now we know you already answered my question. Thank you very much.
Очень хорошо, у нас уже дискуссия завязывается. Кстати,
Very good. We have a discussion. Please, doctors, provide questions, comments, remarks. We have microphones because it will be much more productive. Professor Gazard, yes.
Was about minimal neuroretinal rim width on the spectralis, which is the with the defined basement membrane opening distance, and it's a novel measurement in a spectralis, as opposed to, but it's a novel measurement of a structure with which we are familiar. Many of the newer suggestions of measurements, such as macular cell density, we don't really know where we are with those because they're novel structures to us as glaucoma specialists. But the spectralis neuroretinal, minimal neuroretinal rim width or distance at the basement membrane opening is a structure we understand, but a novel way of measuring it. Do you have a comment on that?
Well, not much. I mean, it's certainly another way to understand and define the thickness of the retinal nerve fiber layer based on a different level of measurement, which is totally correct. But what's happening in research is that there is a constant try to define new parameters or new way of measurement that can better let's say, that can lower our risk of false positive and false negative, and this is a way definitely to go. Then I don't know. I mean, I can't tell you what is my feeling on what is going to be the best in the next future. One of the certainly. Finding new parameters or new way to getting better measurement of the variables we are more confident in, it's probably the way to go. Yeah. Trying to find new technologies, let's say I'm talking about apoptotic cell, the Francisca Cordeiro analysis. It's something that can be very interesting, but just on the research point of view and not certainly on the clinical. So the Spectralis way to improve the performance of their system is definitely one of the most interesting advantages that we have today.
Thank you very much. Very interesting comments. And Andrei would like to add on. He has some interesting idea as well. Thank you very much. It's not a comment, but it's just a question, possibly for the discussion. If we look in mid-average future, 10, 15 years ahead, what do our experts believe? What methods, diagnostic methods, will be mostly used in the future? Current methods, function and morphology study, or maybe biomarkers that quite possibly, we get them more and more with each year, mainly some genetic, biochemical studies and markers. Maybe we should look into this direction. Thank you. Who can comment? Who would like to comment? Roberto? Yes, please.
It's hard to say what we will get in the next future, and I'm sure that all the idea that were raised will go all together. Definitely, I would be more interested in biomarkers than in improved technologies. But I have also to add a comment on that, which is totally, which is partly, let's say, unrelated. So I'm saying, okay, a biomarker will be a very good way to go, and this is definite. On the other side, we have to consider a very important. We are clinicians, so I'm like to focus on clinics. The problem we are having right now is undetected severe cases of glaucoma. We have two big studies coming, one from Greece, from Thessaloniki, the other from the United States, that are showing that 50% of glaucoma patients are undetected. And unfortunately, half of these were seen by an ophthalmologist during the past year. And this is not only in Greece, but also in the United States. And in the United States, one can say, well, the health system is working so good, but this is not the case. And it's interesting to see that these misdiagnosed cases were not small disc, very initial cases, but in the majority were cup disc ratio 0.8, which is 0.7, 0.8, which is advanced glaucomas. So I really feel that it's very important for us to find a new technology to improve our diagnostic performance. But we also need, and probably we need more and more to train physicians to look at the disc with a simple lens to make a correct diagnosis.
Большое спасибо за эту интересную дискуссию. Я тоже поддерживаю мнение профессора
Thank you very much for this discussion. I support the position of Professor Carassa that currently we should and we must take into consideration the complex examination, and the more new methods will come to stage, the more we have the understanding, the better we'll have the pathogenesis and the sense of the disease. It's not simply the identification, it's understanding of glaucoma, which is very different and very difficultly diagnosed. It's my pleasure to give the floor to the next speaker. I have an apology to make. Professor Gazard would like to have a comment. Yes, please.
No, sorry. I was just going to address the two comments that were made. One was a question about future tests, and one was a comment about undiagnosis. To deal with the lack of diagnosis first, there was a study in the UK in a population which is very well served by optometrists, refractionists prescribing glasses. And even in that population, 50%, half of the glaucoma was undiagnosed. Now, of that population of undiagnosed glaucoma, 90%, the majority, had normal pressure glaucoma. So in the UK, where we have ready access to almost free or free eye tests for many of the population, the majority of the normal tension glaucoma had not been picked up because we had individuals who were using pressure as a screening tool, which is clearly wrong and a mistake. So I would just echo Roberto's comment that had they looked at the discs of those patients, had they looked at those patients' nerves, then we would have picked up many more of those cases who were losing vision. So clearly, education at the point of first contact, whoever that may be, is important. Moving on to the earlier question